Thank you for inviting us on to talk about it. We, initially published our first 10 patients with our initial experience with the Javelin forward-based IVL catheter at the Christ Hospital. We really included all 10 patients we started on and really wanted to look at kind of our initial experience and see how this went, how's it apply to a real life scenario to these patients we see and get every day. So we looked at our first 10 patients. We had 16 total lesions in those 10 patients. 6 of them were above the knee. 10 of those lesions were below the knee. For the above the knee lesions, for those 6, 3 of them we had destination therapy of balloon-based IVL. 5 of them we did drug-coated balloon angioplasty. For the below the knee angioplasty, we did 3 bioresorbable stents Esprits for post-ill dissection. Success rate with the Javelin was 94%. I think there was 1 lesion that was unable to be crossed with the Javelin, but otherwise 15 of the 16 it was successful. There was no perforations with the Javelin, no embolizations, no dissections. The 3 dissections we did see were on the post dilatation, the post angioplasty following the Javelin forward IVL, but no vasospasms, no thrombus. So really no true complications related to the device itself. 3 of them that I think the only other thing to add is for every lesion, we used all 120 pulses for each patient. So completely maximize the therapy available.
Yeah, great points, Chris. So I think, very successful in these 16 lesions, like Chris pointed out. And our data mirrors a lot of the data from the Forward IDE experience, where that was 103 lesions, 90 patients, so a bigger subset, of course. But their success rate, their device success rate was 93%, so right on par with ours. A little bit different on the breakdown. We had more below the knee. We had 62% below the knee, where they had 57% above the knee in that trial. And the average pulses, we used all 120, as Chris said. They used 89 on average, so didn't use all the pulses. Additional IVL therapy, which is always a question we get about, do you need more IVL with balloon-based on top of the Javelin? We didn't have to do that below the knee at all. It was all Javelin above the knee. Like Chris said, we had 3, so 19% had additional IVL. In the forward experience, it was 24% had, actually 26% had additional IVL. So the vast majority of these patients are treated with just a Javelin to get the modification of the calcium. DCBs, we did it in 5 patients, as Chris pointed out, all above the knee. In the forward experience, it was 40%, so 31 for us, 40% for them, so a little lower utilization for us. The stents were used 23% of the patients in the forward trial, and we did 3 patients, which comes out to 19%. So pretty compatible or comparable with our first 10. Of course, it's a small subset, but the data looks really good. Safe, like Chris pointed out, similar to the forward trial. They didn't have any episodes of no reflow, no thrombus, no abrupt closure, no perforations, embolization, none of that. They had some dissections. Final dissections in that trial was 1.2%, just 1. And of course, we didn't have any final dissections. They were all sealed. So very safe and very effective, both in the forward experience as well as our series with the Javelin catheter. I think the one device that's probably most applicable as far as how you handle it would be the laser, where you want to go slow with gentle forward pressure. In this case, you want to let the IVL do the work. So you have a little forward pressure, but you do want to go a slow pace. I try to go a millimeter a second, which is similar to the laser technology. But obviously, if you come into contact with a heavily densely calcified segment, you may want to use some more pulses there with your pulse management. So gentle forward pressure, similar to the laser, and just let the IVL do the work through the calcified lesion.
The learning curve for the Shockwave Javelin is, I think, fairly easy, especially if you have experience with balloon-based IVL. The concept of calcium modification, the treatment goals remain similar. I think prepping the catheter, maybe a couple cases with your staff to learn how to flush the window and how to coordinate hands, pinching the wire, pushing the catheter slow and steady while still having a finger on the pulse button. Takes coordination with your staff, but I think the learning curve is going to be a lot quicker than probably we had with balloon-based IVL, where we're trying to learn best techniques. I think it'll get picked up really quick.
Yeah, I agree with Chris. I mean, once you've done a few, you'll have it down, but it is a little awkward when you first get there. You got the two ports, the inlet, the outlet. So there's a little bit different protocol and process there, just prepping it. So it does take you a little bit out of your element for the first case or two, but once you've done it, it's all pretty logical and it makes sense, and it's pretty easy. Below the knee, it's really simplified. I like to go straight to the javelin, and then I like to IVUS right afterwards. And once you've modified that plaque with the javelin, you'll be able to get your IVUS down there easy, get your measurements, and then you're going straight to balloon, and you may need some more destination therapy, but that's pretty simple for me, below the knee. Above the knee, again, I kind of reserve it for the difficult to cross lesions where you just need it to cross, but may not be the best modifier for a large vessel, something that's 6-7 millimeters. And that's where I think the balloon-based IVL is superior. So crossing above the knee and then treating and modifying below the knee. Perfect size vessel in those tibial arteries for this device.
Primarily on lesions, difficult to cross, like you mentioned with your catheter, even on an 014 platform, or you crossed and went straight to your IVUS catheter and had some challenges even getting that through. Those were the obvious cases that you would use forward-based IVL on. The usage in below the knee lesions is going to be where it's mostly going to be used. I prefer, if I can, to use IVUS first, really see where that lithotripsy is going to be most needed. You're going to see lesions on IVUS that may not appear as broadly or as obviously on angiography, that you may want to focus your pulse management a little bit more centered in certain areas rather than others. And then below the ankle, I think if you can target more of your plantars and pedal arteries with the javelin, that's really going to be the area where balloon-based IVL hasn't been able to give us a significant advantage quite yet based on the available sizes. And maybe we don't need balloons down there, and javelin may be destination therapy at some point. But I think taking the curvature of the ankle, it's really an advantage. Three of them. I think my number one takeaway is slow and steady. Firm forward pressure. Let the lithotripsy do the work. Don't try to shove the catheter through it until it's ready. And then really focus your pulses on the area of densest calcium.
Yeah, I agree with Chris. I think the number one takeaway is, first of all, I think lesion selection comes into play for all these cases. But I think slow and steady, once you're using the device, slow and steady, let the lithotripsy do the work, not the forward force. You just want enough forward pressure to keep things moving through the plaque, through the lesion. But you do want to let the lithotripsy work. That emitter is forward shifted 3 millimeters from the tip. So your energy is out in front of the tip, and that's going to give you that modification out in front of the catheter, help you cross. And then you're getting the array, the radius out the side, so you're going to modify as you go through. So yeah, I think the slow and steady, and then optimize in those heavily calcified segments where you may need some more pulses. Pulse management is the key.